2, 1. Good evening. This is Dr. John Bennett, televising from Miami, Florida. Tonight we have a hangout with two distinguished gentlemen. We have Richard Moon, MD, anesthesiologist from Duke University, and we have Larry Creswell, MD, well-known hangout person. We've done a couple of hangouts together. One on a M Health app done by Jay Widner of Mayo Clinic. And Larry is a true, as I was saying to Richard, a true triathlete. He just doesn't do one race a year. I'll just quickly relate how I got to meet these gentlemen. I read Larry's blog, athletesheart.org, and he basically deals with the health issues in triathletes. And he mentioned an article about swimming-induced pulmonary edema, and he mentioned Richard's name about his recent study. So I thought, well, we'll put these two guys together and watch the fireworks. So first was, hi, good evening, Larry.
Good evening, John. How are you?
Very good. Very good. And good evening, Richard. Okay, I guess we can start off. Richard, just introduce yourself and what you do and stuff, and then talk about your paper, and then we'll take it from there.
Sure. I'm Richard Moon. I'm an anesthesiologist and diving physician at Duke University. I have been working on the problem of immersion pulmonary edema for a number of years. We're trying to understand what causes it and how to prevent it. And I'll just run through a few slides.
Okay.
Share my screen.
There you go. There you go.
Okay. Can you see the slide?
Yes, 37-year-old physician. Yeah. Okay.
So this is a very physically fit individual who contacted us, and after an initial open water triathlon training session, she felt a bit more fatigued than normal and experienced what she called a wet cough. She didn't really think much about it, but then did a second open water swim. It was quite cold, although she did have a wetsuit. And after 200 meters, she was severely short of breath. She called for help, and she was coughing up copious amounts of blood. When the EMS arrived, her heart rate was around 200 beats per minute. Her oxygen saturation was 55%. And her chest x-ray, when she got to the hospital, showed flagrant pulmonary edema. She had some investigations which ruled out anything wrong with her heart, and she then proceeded to be a little more relaxed about her training, having had 2 episodes, one of which put her in the hospital. This condition was actually described in the late 1980s. It was presented at a meeting by a cardiologist from Britain named Peter Wilmshurst, who then wrote up his experience in the Lancet in 1989, and the title of his paper was Cold-Induced Pulmonary Edema in Scuba Divers and Swimmers and Subsequent Development of Hypertension. And he had a cohort of individuals who had this peculiar condition, many of whom, when he followed them, it did indeed go on to develop high blood pressure. And he studied them in response to a few stressors. He looked at the top panel is arterial pressure in response to exercise. Cold was a cold pack put on the back of the subject's neck, oxygen breathing, and then ice plus oxygen. And as you can see, there was a significantly greater increase in blood pressure in response to these stressors. And when he measured specifically the forearm vascular resistance, he found that cold, for example, caused an over 2-fold increase, greater increase in forearm vascular resistance. And what he proposed was that these people were basically going into heart failure. They had some exaggerated vasoconstriction. Their arterioles were constricting to a greater extent than normals, and causing an increase in blood pressure, and in association with what happens in immersion, which is a redistribution of blood into the thorax, this caused the pulmonary edema. And then you go back a few years to an investigator named Lang, he actually measured this effect of increase in blood volume in the chest by taking X-rays in the water. And the top panel is the upright position. He measured the heart in 3 dimensions. These numbers are in centimeters, of course. When you lie down, your heart gets a little bit bigger, but in water, it gets bigger still. And he estimated the change in volume shown on the right. So in the upright position, heart volume was around 650 or 700 mLs. And when immersed, there was an additional volume of blood, which comes from the legs, mostly. So here you have somebody standing in the dry. There's a tendency for blood to pool in the veins of the legs, especially. But because blood and water have almost the same density, when you get into water, there's some of this blood is redistributed back into the chest. Lungs become more engorged with blood, and the pressures within the blood vessels inside the lung increase as well. Now, what our article looked at this condition. It was the first author is Dion Peacher, who's a junior person at Duke. She's now gone on. She's a cardiac anesthetist now at University of Pennsylvania. She reviewed the literature and found that since 1984 there had been 292 cases of SIPE, swimming-induced pulmonary edema, described, often in swimmers, sometimes in divers. And what she did was she put together some possible risk factors described in as many of these cases as she could identify. So cardiac abnormalities included hypertension, which had been described by Wilmshurst, wall motion abnormalities such as there was 1 case of alcoholic cardiomyopathy, 4 cases of Takotsubo cardiomyopathy, and then a number of them had myocardial ischemia, left ventricular hypertrophy, and so on. So all of these cardiac anomalies, and indeed some cardiac risk factors that might have predisposed them to coronary disease, and then some pulmonary conditions. So asthma and exercise-induced cough indicate bronchospasm, and in the setting of bronchospasm with immersion, there can be excessive preloading of the heart due to the increased negative intrathoracic pressure during breathing against internal breathing resistance. So putting all that together, almost 50% of the civilian cases had some potentially predisposing factor, and about half, just over half, had no obvious predisposing factor. And amongst the military cases, a lot of military cases, mostly in special forces trainees, of course none of them had any identifiable predisposing factors. They'd all gone through careful screening for hypertension and other things. So the point being here that if you identify somebody who's got emergent pulmonary edema, has had emergent pulmonary edema, then it is a reasonable policy to investigate them for some of these conditions. Now, I was mentioning to John earlier, this is a study done by Catherine Calder-Becker, who's a triathlete who lives in Montreal, and she sent out an electronic survey via USA Triathlon, and she got 1,400 respondents, of whom 20, about 1.5%, reported having experienced symptoms highly suggestive of emergent pulmonary edema. She did an analysis suggesting that hypertension is a risk factor, as we've known already. Fish oil, I'm not quite sure what that has to do with it. Wetsuit use and long course, and those of you who are triathletes, I'm not one by the way, know that there are various degrees of severity of triathlon, and the ones who were doing the long course were at greater risk. So we started looking at this. We had an idea that perhaps the main factor here was immersion of the face in cold water, that we thought this might have something to do with the diving reflex, And so we constructed this setup in our hyperbaric chamber. The chamber is actually irrelevant to this part of the study, but this showed a volunteer immersed in water with a hyperbaric head tent over his head. And through this tubing, we were able to independently control the temperature of the water around the head. So we had either cold water, and then warm or cold water in which he was immersed with either cold or warm water around the head, and then or warm water and cold or warm water on the head. So we had all the combinations, and we were able to look at the hemodynamic changes that went along with that. One of the other interventions that we did was we had what was sort of laughingly called the dunk, where we suspended the individual above the water on a rescue litter and then literally dunked him or her into the water, and we measured the blood pressure response to that. And here's an example. This is not an immersion pulmonary edema susceptible individual, but it gives you an idea of the data that we were able to obtain. So here's arterial pressure, and this is 28 degrees centigrade water, so it's thermoneutral. And you can see that after immersion there was a slight decrease in blood pressure, which then came back to slightly above normal. So the mean pressure went from 109 in this individual to 116, a very small change. But in cold water, in 19 degrees centigrade water, you can see that the blood pressure, the mean pressure, went from 105 to 132, a much greater change, not surprisingly, but we were more interested in the pressures on the right side. So the orange tracing here represents pulmonary artery pressure, the blue is central venous pressure, and there was a change in pulmonary artery pressure. It went from 14 to 24 in warm water, and it went from 15 to 26. Seemingly not that big of a difference, but in fact, if you look carefully at this, there's a little spike here, which is not fling at all. It's actually real systolic pulmonary artery pressure of 92 millimeters of mercury. So there's a very transient but quite profound increase in pulmonary artery pressure. And here you can just see the setup. This is a person, this is cold water, as it turns out. Our subject has got a towel around her, and here's, you can see the experimental staff had the benefit of wetsuits, and here's the dunk. So here's the person, she's smiling, but she wasn't smiling for long because underwater it was quite cold. Now we did this, we took a group of volunteers who had experienced immersion pulmonary edema. We had 10 of them. We ruled out anything wrong with their heart. We investigated them all except one for coronary disease. None had coronary disease, and none of them had valve disease. And we exercised them in cold water and measured their hemodynamic response, and then we gave them sildenafil, Viagra, 50 milligrams orally, and we repeated the study. And these are the immersion pulmonary edema susceptible individuals. There were 4 males, 6 females. The controls had a slightly different gender distribution. The ages were similar, although the immersion pulmonary edema were slightly older. What we found was that the individuals who had immersion pulmonary edema had significantly higher pulmonary artery pressure and wedge pressure during exercise in cold water compared with the controls. We had 20 controls. And here's an example. And by the way, the Viagra lowered the pressure. And one of our volunteers was so enthusiastic about this that she asked for her hemodynamic results, which we sent to her, and she got her physician to prescribe Viagra for her, and since then she hasn't had any episodes. She had 5 episodes before and none since. This interesting paper by Dr. Gemp in France described 54 divers with dyspnea during diving. So these are people who'd experienced immersion pulmonary edema, and he described myocardial dysfunction as elevated troponin levels with ECG and/or echocardiographic abnormalities, so regional wall motion abnormalities. And of these 54, 3 required CPAP in the hospital, 2 required inotropes, and 52 out of 54 had complete resolution within 6 to 24 hours. And of those patients, 39 patients, 72%, had no myocardial dysfunction. The remainder did. 12 had EKG abnormalities, 13 had global or segmental hypokinesia. 3 patients had concentric LVH, obviously associated with pre-existing hypertension. 3 patients were tested with exercise tests, and 6 had coronary angiography. So despite these wall motion abnormalities, they were all negative for significant ischemia. And the question is, what was going on here? Was this hypoxia-induced myocardial damage that was transient, or did they somehow have some kind of acute cardiomyopathy that resolved quickly? It's a little bit of a mystery as to what exactly they were seeing, but the point is that there are all kinds of cardiac problems that occur at the time of the event that seem to go away. Now, part of our study was to look at the effect of fluid loading, and the reason to do this was that there was a paper from the Israeli Special Forces several years ago where it was one of their first papers where they had preloaded these guys before they did their 2 or 3 kilometer swims with a lot of water, and they had a high incidence of emergent pulmonary edema. So they thought that perhaps water loading, fluid loading, might have had something to do with it. So what we did, we had a group of controls that this is not the same study I just showed you, it's a different study. And we had a group of emergent pulmonary edema susceptible individuals. And we exercised them in cold water for 40 minutes. So this is 20 °C water for 40 minutes. And the orange bars represent emergent pulmonary edema symptoms, cough or dyspnea. The purple bars are those who stopped less than 40 minutes, so they stopped prematurely. And the red bars represent those who had a greater than 10% drop in FEV1 on spirometry. And these numbers are percentages. So the controls who didn't get a fluid load, a few of them had manifestations arguably of emergent pulmonary edema, and maybe these people were in fact susceptible. We don't really know. We gave others, on another occasion, we gave them Pedialyte, 2 liters of Pedialyte before exercise, and some of them had some manifestations. Now, of the SIPE-susceptible ones, these are the same data, so no fluid load, and up to a third of them had manifestations of emergent pulmonary edema in our experimental setting. When we gave them Pedialyte, there was a significant increase. About 90% had a drop in FEV1, which is consistent with mild emergent pulmonary edema. So clearly, fluid loading is a bad idea before a cold water swim, particularly if you're swimming hard, i.e. in a triathlon. So the hypothesis was that we could identify SIPE-susceptible individuals by the response to cold water immersion. And the question is why. We've shown that pulmonary artery pressures are higher in this cohort. Why is that? And there are a couple of possible reasons. One is that they've got decreased venous compliance. That is to say that their venous system is less compliant, has less space, if you like, for redistribution, and this extra blood then gets redistributed into the central compartment, into the heart and lungs. And another possibility is that this is due to impaired diastolic left ventricular filling. In other words, because the ventricle has to empty, we all know that, but it also has to fill, and when it fills, it requires a certain pressure. And here's a plot. So this is this sort of pseudo square here represents the pressures and volumes within the left ventricle. So here's the mitral valve opens and the ventricle starts filling, and once it's full, the mitral valve closes because the ventricle starts contracting. The pressure then goes up, the aortic valve opens and then ejects, and then relaxation back to mitral valve opening. Now, in somebody with a stiff ventricle with reduced ventricular compliance, the curve might look something like this. So the ventricle is able to fill to the same degree, but the pressure is higher. And if you impose upon that additional filling due to the fact that there's extra blood in the thorax, then the left ventricular end diastolic pressure, i.e. the pulmonary capillary pressure, may be even higher yet. And we think this is actually a major player in this condition. Now, what happens if you see a case of emergent pulmonary edema, and how do you deal with it? Well, oxygen, if needed, certainly, and a lot of these people do need oxygen. They don't need diuretics, because as soon as they're out of the water, the hemodynamic change that caused the emergent pulmonary edema to start with is reversed. And the one thing that can be done is to give a beta-2 adrenergic agonist, which helps the sodium-potassium pump and helps empty the airways more quickly. So albuterol is a good therapeutic agent. Then, so once they're over their acute episode, what to do then? And certainly, if somebody is 25 years old in the Navy, they don't need much in the way of investigation, but a lot of these people are older, they have hypertension, diabetes, they have elevated cholesterol, they're smokers, etc. Then I think they need an echo and a stress echo, certainly to rule out valve disease and to make the first step towards excluding silent coronary disease. Spirometry, if indicated, to look for reversible airways obstruction. And certainly before they're allowed to go back into the water, they should have their risk factors managed. And the most common risk factor is hypertension. How long should they be treated before they can try triathlons again? I don't know the answer to that, but certainly long enough to bring their blood pressure back to normal and to enable the heart to remodel itself. So that's all I have in terms of a formal presentation. I'm happy to answer any questions.
Very good, Richard. Thank you very much for an excellent, clear presentation. And I'll turn it over immediately to Larry, because I'm sure he has a lot of comments and questions.
Well, thanks, John, and thanks, Richard. It's I think this is an absolutely fascinating medical problem, and maybe it gets into the weeds for some people who are non-medical, who might have tuned in. I think one of the important issues is case identification or definition. How would you sum up for the non-medical person what counts as an episode of SIPE?
Yeah, good question. I would say disproportionate shortness of breath, cough, and sputum. Sometimes, perhaps the majority of the times, there's blood in the sputum, but there's always disproportionate shortness of breath. And I think it's important for triathletes to realize that if they experience that, they shouldn't press on and hope for the best. They should just take a break, swim over to the rescue boat, and get checked out.
Yeah, I think that's certainly good advice. Sometimes it's hard to keep that advice in mind on race day, no doubt. But I think it's important for people to realize that what we're not talking about is a problem with the breathing because of some sort of inhaled exposure, for instance. So we're not talking about breathing in something from the gasoline that's used in the nearby motorboats, and we're not talking about a problem that gets started because of inhaling some water by mistake, right?
Right, exactly.
So we're sort of talking about something that happens when the swimmer has done nothing particular other than jump in the water.
Yeah, that's
Exercise, I guess, exert themselves. And I think that's the important thing to remember. And then certainly good advice to find the nearby kayaker or paddleboarder so that you can get some help if you have shortness of breath during a race. It seems to me that very oftentimes when people have shortness of breath at a race, it's easy to attribute that to the anxiety of the moment or the hype that goes with getting the race started. And it seems to me that when I talk to people who've had troubles breathing during a race, even if they stop, it's the rare person who actually thought afterwards, after they were feeling well again, to actually go to the doctor and get checked out. Has that been your experience, Richard?
Oh yes, absolutely, yes. Once they're feeling better, they just tend to blow it off, and the other problem is that it's a condition that hasn't really reached the consciousness of many doctors, and a lot of physicians don't really know what to do when they're faced with these patients.
No, I think that's right, and I think that very oftentimes when you're thinking about a triathlon crowd or an open water swimming crowd, you're thinking of generally healthier than average sort of people, and you're talking about a group of people where many people in the group don't have a primary physician, perhaps, and it's always an issue about, like, where do they turn? Like, on race day, do they think to go to the emergency room? Should they visit their primary care doctor, 2 days later when an appointment can be had? It's hard to know just what to tell people. What do you think about that?
Yeah, my advice is to go to the emergency room so that at least a problem can be properly documented. So if they get a chest X-ray or even pulse oximetry to show that yes, their pulse ox was down in a range where it clearly isn't normally, then a problem is identified. Whereas if they go 2 days later to their doctor and they say, well, feeling a little short of breath during the triathlon, there's not very much that anyone can say. The physician doesn't really know how severe it might have been.
Yeah,
right.
Excuse me. The race, I guess, Larry, there are race boats all around during a triathlon in the swimming part.
Yeah, that's right. So I think both at a triathlon as well as at an open water swimming event, that safety planning sort of sets up a situation where there are various rescue people on the course.
Right.
Sometimes that's in a boat or a rowboat or a motorboat. Sometimes that's those people are on a kayak or a surfboard or even just a swimmer in the water with a wetsuit on sometimes.
Would they be outfitted? Well, I'm sorry. Would they be outfitted with a pulse ox, the race boats, normally?
No, I think that would be really unusual in the setup for the typical triathlon. That's
Right.
not to say that if you were in a longer distance swimming race where there were real boats that had ambulance type capability on the water, that you would have that. But I think that's a pretty unusual situation. Just thinking about triathlons generally.
Would you suggest that, Richard, that all race boats have pulse ox? Because it's such an easy piece of equipment. I mean, it's a small piece of equipment. Would that be good for screening people on the race boat to see if someone came over and says, "Hey, wait, I may be suffering from sudden induced pulmonary edema"? Would you check me out?
Far be it from me to set the standards for triathlons, but Larry, am I correct that there's usually a medical tent attached to most big triathlons where the person could be taken and where they often would have pulse oximetry and the ability to listen to the chest and so on?
Right, I think that's right. I think that every triathlon that's sanctioned by USA Triathlon, for instance, would have a safety director, which could oftentimes be a physician, but there often is medical support available right at the transition at the shore. Very often that's in conjunction with local EMS providers, for instance, but all of the equipment to monitor the oxygen saturation would be at shore. I agree with Richard in the sense that the best advice is that if you have unexpected shortness of breath when you are swimming, that you stop. And my advice to the people who want to listen to my advice is that if you're providing safety at one of these races and an athlete stops because of shortness of breath, that they not be allowed to continue.
Yeah, I think
It takes both the athlete plus the rescuer to make that happen, because the swimmer is now some distance from shore, and it takes someone from the race to say, no, I think that's it. Unexpected shortness of breath is a reason to stop. We need to get you back to shore.
Have you ever seen a case during a race, Larry?
I can't think of a case where I've been there and seen it happen, but I have heard a fair number of stories from people over these last 2 or 3 years where they relate experiences that make me think SIPE was the diagnosis, even if they didn't go to the hospital and have a chest X-ray or oxygen saturation to document it. I not a doubt in my mind that this happens, John.
Richard, at what level of pulse oximetry would you consider for a physician that's checking someone out to be, you better go to the emergency room? What number would you say?
Oh, well, I would. It's not just the pulse oximeter reading. It's the entire picture. If somebody's short of breath, they've got some crackles on listening to their lungs, and their pulse ox is lower than you would predict for an athlete.
Right.
I would recommend that person go to the emergency room.
Okay.
I think that's right, John. I think that in healthy athletes, recreational athletes, anything but a normal PO2 or oxygen saturation, there's something wrong.
Would you say 96, 90, 95,
Right.
94?
Well, we should be in the high 90s for sure.
High
And
90s,
if you're
yeah.
not and don't have a known medical problem to account for it already,
Right.
I think that's a reason for concern on race day.
Okay. Okay. Very good. Any more questions, comments, Larry?
I could ask questions all day.
Well, you have the man here.
I know I do. It's awesome. I appreciate it. I'm interested in the risk factors that you talk about in people who are found to have SIPE or are susceptible to having SIPE. And you mentioned tonight, and you see it mentioned often, that hypertension is a risk factor. Is it treated hypertension, or is it hypertension that's unrecognized and identified at the incident evaluation that's the issue?
Yeah, I think it's probably not the hypertension per se, because hypertension during exercise is a normal phenomenon unless it's disproportionate. I think it's the left ventricular hypertrophy that goes along with it. So I think it's long-standing hypertension that is not optimally controlled, and my hunch is that this is mostly a feature of non-compliant left ventricles. I think that's the major part of it. We're still working on the data, but the other possibility, the venous compliance issue, I don't think is going to pan out. At least our preliminary data suggests that it isn't that, but we're still working on that. And of course, there are the other, I mean, some of these people do have silent coronary disease, and some of them have valve disease.
Right.
We had a very interesting lady who came to us to participate in the study. She had normal echo, a normal exam, everything was completely normal. She might have had trace mitral regurgitation, but I mean, it was basically a normal echo. And so we put her in the water, we exercised her, and she actually did develop mild symptoms. And when our cardiologist was reviewing her echo, he calls me up and says, "Oh my God, you've got to call this lady. She's got to get her mitral valve looked at. She's got 4+ MR." And so I sent her an email immediately. She immediately went to see a physician who blew off the whole thing and said, "Well, you don't even have a murmur, so there's no way there's anything wrong with your mitral valve." But it was what happened was, as soon as she got into water, the mitral ring dilated sufficiently to create 4+ MR, where she had virtually none in the dry. So I don't know how many of those there are. That might be common, or it might just be a one-off. But certainly valve disease is one of the things that can cause sight.
Yeah, that's
Very good.
fascinating. And the mitral valve in that case could also be affected by just the episodic pulmonary hypertension, that to feed into
Sure.
that, of course. The information about the hydration, the hydration status is also interesting because, of course, most of these races that we're talking about, both triathlons and open water swimming events, happen during the temperate times of the year. It can be very warm on race day, and the typical advice that's provided to participants from their fellow participants or from the race itself is to hydrate amply the day before and the morning of the race before you get going. And maybe that's something that we ought to reconsider, or think to put a bullet point that is, unless you've had troubles with breathing. I don't know. That's a tough one, but probably an important one for the people who are affected.
Yeah. Well,
Go
certainly.
ahead.
What I was going to say was that people who triathlons tend to get addicted to the sport, and the triathletes get addicted to the sport, and of course, even after an event, they want to go back, and maybe they've got some antihypertensives going. But the one piece of advice I give those individuals is don't load fluids before the swim. Load up for the bike and the run as much as you want, but not before the swim.
That sounds like a good piece of advice. I was going to ask Larry, on a hot triathlon day, do the athletes typically fluid load before all segments?
Yeah, I think so. I think the typical practice would be to amply hydrate the day before and the morning of the race.
Okay, so on a hot day, Richard, you would
Well,
advise the athletes not to
in
fluid.
general, if 1.5% of triathletes has emergent pulmonary edema, that means that 98.5% don't.
Right.
And so
Right.
I wouldn't suggest that everyone avoid fluids.
Right.
I would limit that advice to only those who might have experienced an episode before, and they're trying to survive.
Right. Okay. Very good.
Richard, what is your experience with the problem in a setting other than open water swimming? Do people have this problem manifest at the swimming pool?
Yeah, that's a good question. I've not heard of it in a swimming pool, but there are a couple of interesting issues here. One is that if you look carefully at some accounts of people who have drowned, it appears that they might actually have experienced emergent pulmonary edema rather than drowning per se. And another issue, of course, is divers, and divers get it as well. Usually divers are not working as hard as triathletes when they're underwater, and so I'm not quite sure why some of them get it with just paddling around in the coral reef. The other interesting thing is that if you look at people who swim exclusively, you don't hear about this much, if at all. Whereas people who do different types of things, so triathletes typically, well, of course, they're training in 3 different sports, but there's some interesting data looking at myocardial wall thickness and left ventricular cavity dimension. And different types of athletes tend to get different types of remodeling of their heart. So weightlifters are the extreme. They tend to have very small cavity dimension and very thick ventricles. Right. Whereas swimmers are sort of intermediate. Triathletes tend to have thicker ventricles than just plain swimmers, maybe because a lot of them maybe lift weights partly. So I think there may be a sport and training specific effect here, that certain types of training make people more susceptible than other types of training. but that's just a hypothesis.
Got it. Does the
Okay.
problem happen in children?
Yeah, I don't know. I don't know the answer to that. I've not heard of it in children, but again, of course, when children are paddling around in the water, they tend not to be working terribly hard.
Right.
Not triathletes.
But there, I mean, I ask only because there are in the hundreds of youth events put on across the country each year in triathlon, focused entirely on youth participants, and a fair number of those have open water swimming. And it seems that when I've been to some of these larger open water swim events, there are a fair number of say teenagers that are participants. But I guess it does get at the denominator. I mean, like how many people are out there doing it, and if we're talking about a small part of that, maybe it's hard to latch on to what the problem might be in young swimmers.
Okay, very good, gentlemen. I'd like to thank you, Richard, for spending the time and coming out to help us to enlighten us on what's going on with swimming-induced pulmonary edema. And thank you, Larry, for putting this together. And any topic you guys have in the future you want to discuss, just let me know. And I'll send you a copy of this show. So thank you, gentlemen.
Well, thank you, John, and thank you, Richard, both.
Nice to meet both of you. Thanks very much.
Okay, gentlemen. Good night. Hold on. We'll chat for a second after the broadcast ends.